a surge of insulin secretion that goes down, and usually it takes 240 minutes total between a peak and a valley, while in type 2 diabetics it's a flat response. There's no response. When glucagon is also deficient in patient with type 2 diabetics as well as 1. And glucagon is one of the hormones that are secreted also by the pancreas to increase glucose in the blood after a hypoglycemic event. And also, and this is the glucose response, when the diabetic rise while normal patients go up, peaks around 1 hour and come down to a normal level. I'm showing this physiological response and the pathological response of diabetics because we're going to use this concept to identify the new medication who works on this idea and find out how can we use them in combination with the old therapies. So what's new in diabetes management? The few words about or introduction about where do those or do these new medication come from? Really, the glucose homeostasis or the metabolism of glucose is dependent on a complex interplay of multiple hormones between the gut, the pancreas, the brain. There is a nice network among all these organs in order for glucose to be metabolized efficiently. Insulin and amylin, for example, amylin, probably this is a new, they both are produced by the pancreatic beta cells, and diabetics, both type 1 and type 2, are both deficient or insufficient in type 2s for both those hormones. Glucagon produces the pancreatic alpha cells. Gastrointestinal peptide, remember I said the gastrointestinal tract also play a part of the loop in glucose metabolism or control. And the gastrointestinal peptide is a group of amino acids that includes called glucagon-like peptide 1 and gastric inhibitory peptide, GIP. They're all produced by the ileal cells in the gut, the small intestine. So abnormal regulation of any of these substances may contribute to a clinical presentation of diabetes. So the basis behind the new diabetes drugs is the GLP, glucagon-like peptide 1 deficiency, as I mentioned, is present in type 1 diabetic and possibly in type 2, type 2 and possibly in type 1. Also, amylin is deficient in type 1 diabetics and relatively deficient in insulin requiring type 2, which means advanced type 2 diabetics. So we use those two facts to kind of find new medications to improve those deficiencies, and we do have those current medications, FDA approved medications. So the GLP-1, it's called incretins, the GLP-1 or glucagon-like peptide, what does it do? What is the importance of these hormones that we make naturally and it's deficient in type 1 and type 2? What do they do? First, it gets secreted upon ingestion of food. Second, the beta cells start working under this influence of the glucagon-like peptide that is secreted from the gut. And then the alpha cells also, the glucagon secretion get dropped because of those GLP-1 substances, and then the liver also decrease glucose production or output, so it has multiple function at different organs in the system. And with the stomach also, it decreases the rapidity of movement of the muscles of the stomach and decreases gastric emptying, and also it goes to the brain and promotes satiety and reduces appetite. So it has multiple function. So basically, if we take an oral glucose versus intravenous glucose, which is different because oral glucose go through the stomach, stimulate the cells to produce, and the ileal cells to produce the glucagon-like peptide, and therefore you get a nice insulin secretion response. While if you give people intravenous glucose bypassing the gastrointestinal tract, you do not get this glucagon-like peptide increase. So, as I said, upon ingestion of food, it stimulates glucose-dependent insulin secretion, so it goes on the pancreas, suppresses glucagon, slows gastric emptying, and also all of these effects also goes to the brain to decrease appetite. So what are the therapeutic potential? The problem with the glucagon-like peptide that we naturally make, it's very short-lived. It gets destroyed immediately by our body, by certain enzymes, and therefore the manufacturer tried to use this fact and produce something that long-lasting, that can be used to work like a glucagon-like peptide. So because it has a short half-life, less than 2 minutes, and rapidly degraded, so the glucagon-like peptide were found, they actually invented the exenatide, which we all know as Byetta. It is hard to degrade, it lasts long in the system, and it does all the activities of the glucagon-like peptide. Or they found a medication that inhibits the enzyme that does this destruction of this very important peptide. So by inhibiting this enzyme, we will have a high natural glucagon-like peptide. And as you probably all heard about Genovia, which is the sitagliptin, which is by the name of Genovia. So we have the Byetta and Genovia came from this concept of the glucagon-like peptide. One is a glucagon-like peptide substance, and the other one is inhibit the enzyme that destroys it, and therefore allow the natural substance to stay in the system and work further, and does all these effect from brain to stomach and pancreas, as well as the liver, and improve glucose homeostasis, or glucose abnormalities, or metabolism, if you might call it. So the Byetta really, the exenidine, this comes from, it's a naturally occurring component, and I'll show you where it is. It comes from this heloderma. It's in the salivary gland of this glia monster, they call it, and they found it, just different amino acids, they modified it, they made the Byetta from it. And the same thing, the exenatide, it works like a GLP. The only one difference, it is long acting. As you see, it's resistant to the degradation of the enzyme, and therefore lasts longer and exert its work for a longer period of time. So it improved postprandial hyperglycemia because it works on increased insulin secretion, and also decrease the rate of nutrition absorption or nutrient absorption, and decrease food intake. It works on hypoglycemia. When glucose reaches normal levels, also, it doesn't work anymore. It does not cause really hypoglycemia, and only the risk increases if you combine it with sulfonylureas. And weight gain is actually one of those problems or challenges we have. It decreases weight. There are studies to show that Byetta help in weight reduction. And of course, we don't have very long-term control data available. And what is the FDA indication for using exenatide or Byetta currently? It's indicated as an adjunct therapy to improve glycemic control in patients with type 2 diabetes, in addition to metformin and sulfonylurea like a glipizide, glyburide, as well as in combination with metformin and sulfonylurea. But when you have a combination that has not achieved its, people who did not achieve their glycemic control, and also they found that 1 year, there was a couple of studies and even longer studies now, that exenatide has improved the beta cell function and induced weight loss compared to insulin glargine by itself. These are just the study to see when we combine them, how much, what is the percentage of achievement of glycemic control, meaning less than 7% hemoglobin A1C if you use it in combination with metformin and sulfonylurea, and in addition to the Byetta, the glycemic control improves. These are for weight. It helps in weight reduction. The combination with exenatide, see the weight drops by far much more than the sulfonylurea usually raises weight. Metformin decreases weight, and the exenatide further decreases weight. And the combination helps in, if not, just maintaining weight. The main side effect of Byetta is really nausea, vomiting, feeling jittery, as well as these are compared to placebo, but the major thing patients complain about in clinical practice is nausea and diarrhea and occasional dyspepsia. The recent FDA warning, I'm sure many of you have heard about. It's there was a report of 30 patients received exenatide or Byetta have developed acute pancreatitis, which may possibly link to it. An association between the two has been suspected, and therefore FDA has advised patients receiving Byetta exenatide to seek medical advice if they have developed any symptoms of pancreatitis. I do have 2 patients who had, one was silent and one was frank pancreatitis, and precautionary info to the product label was also included. It's not a black box warning, but it was including in the package insert of Byetta exenatide. So now we talked about having a chemical structure that looks like a glucagon-like peptide. Now the medication that inhibit the enzyme that destroys the glucagon-like peptide, allowing it to increase in the circulation and therefore achieve its function naturally from our natural production of GLP. So mechanism of action of these inhibitors that inhibit those enzymes, they call them the DPP4 inhibitors. It blocks this enzyme, as you see, and therefore we will have a lot of GLP left in the circulation, and we will have decrease in the inactive form, and therefore it can exert its effect, as I mentioned, on the beta cells, on the glucagon, on the liver, etc. It is an enzyme. The DPP is an enzyme in our system. It deactivates a variety of other bioactive peptide, including the GIP, and its inhibition could potentially affect glucose regulation through multiple effects. And these inhibitors, unlike the GLP-based therapies, can be administered orally. So this is one plus, and I put it in yellow because this is a big plus compared to the Byetta, which is given by injections on twice daily basis. This is given orally. So one given by injection, this is given orally. So this is a big plus for this medication, and which is called Januvia. I'm sure you know about it. And metformin has been shown to modestly enhances glucagon-like peptide secretion, making it very attractive option for a combination therapy with Januvia and further DPP 4 inhibitors that are in the process to be approved by FDA. So the sitagliptin, which is Januvia for simplicity, it's an oral selective inhibitor of this enzyme and indicated as a monotherapy and or in combination with metformin or Actos or Avandia, and recently was also approved with sulfonylurea. It is the usual recommended dose is 100 milligram. We give it either in single or divided dose, as well as we modify the dose according to renal secretions. They're available in the market 25, 50, and 100. And in clinical studies, it significantly improved the hemoglobin A1C, fasting glucose, as well as post-meal or postprandial glucose, and it lowers hemoglobin A1C by around 1 to 2% again, and also it does not work on normal glucose, people who have normal glucose. So the risk, when in monotherapy, the risk of hypoglycemia is minimal. The main adverse event of it is really upper respiratory tract infection. Many people come with a complaint of a stuffy nose, sometimes goes away after a few weeks of using it, and most of the adverse reaction were really similar to placebo, except of course there is an incidence of hypoglycemia when it's combined with other medications, as well as it has not shown any weight effect in relationship to placebo. So it's neither cause you to lose weight or gain weight, and it's a nice adjunct and bring hemoglobin A1C in combination with other therapies very nicely down. So there are a lot of new therapies are being evaluated for approval, and most of them hinges from those facts and these hormones that they were found to coexist in our intestine or from the pancreas in order for us to achieve glycemic control. And we do not concentrate only on the insulin secretion and the sensitization of muscles to insulin. Amylin, remember I said